So today we're going to discuss a topic that a lot of you ask about, a lot of my patients have top of mind: male sexual function, dysfunction, and optimization. Dr. Jabran Sheikh, I'm a board certified dermatologist, longevity medicine expert with a focus on men's health. So of course this is a topic that is near and dear to my heart and is something that I think about a lot. My patients are often interested in their younger years, optimizing sexual function to have the richness of their sexual lives be as full and complete as possible, to protect themselves from diseases and to be able to last longer, to go harder, really. As they get older, as they enter into their 40s, 50s, and 60s, problems like erectile dysfunction can start to emerge. And as many of my patients enter into their later years, they can be quite disabling. So erectile dysfunction and addressing some of the mechanical issues are incredibly important. Libido, on the other hand, that's the desire or drive for sex, can be an issue at any age. And for many of my patients who have constitutionally low to moderate libido, they often want to increase their libido. They want to expand upon that. And so that's a topic that we can talk about in terms of optimization. So when we think about optimization of male sexual function, we first have to talk about erectile dysfunction. What is erectile dysfunction? Simply put, erectile dysfunction is the inability to maintain an erection of sufficient quality and hardness to complete an active sex. It may not be able to get hard to begin the sexual episode, or it may initially be hard and then after a period of time get soft and is unable to be maintained throughout the sexual episode, and that would also constitute erectile dysfunction. So inability to achieve an erection initially, or an inability to maintain an erection. So I start with, when a patient is presenting with erectile dysfunction, we think about it in a couple of different categories. First, I think about it as organic, and then second, I think about it as psychogenic, and third, I think about it as mixed. So when I think about organic, we're talking about something physically wrong with the erection, right? And so what that can be vascular problems, problems with the blood vessels. Of course, the erection, in order to get engorged, it has to fill with blood. And so consequently, if there's damage to the blood vessels, such as an untreated high blood pressure or very advanced cardiovascular disease, the patient has bad control of their cholesterol and untreated blood pressure problems for many years, erectile dysfunction is going to be a result of that. Similarly, neurogenic problems, classically in diabetes. So diabetes, when in its more advanced stages, can cause damage to the small nerves, including in the penis, and that can lead to a neurogenic erectile dysfunction, as well as in certain diseases like multiple sclerosis, after stroke, issues like that. So that would be neurogenic erectile dysfunction. And then there's mixed organic dysfunction, in which there's combinations of both vascular problems and neurologic problems. That would be mixed organic erectile dysfunction. I would then talk about psychogenic erectile dysfunction, which is predominantly a psychological issue. Very common, particularly in younger men, where maybe a man has an experience in which they're not able to achieve an erection, or they lose their erection during sex and they sort of psych themselves out in subsequent episodes, and it becomes a sort of vicious cycle. And so I see that all the time, again, particularly in my younger patients. But a lot of cases, it can be mixed, right? There can be an element of vascular problems or some mild to moderate diabetic changes, and then that leads to an inability to perform, and then that can also lead to this psychogenic component as well. So in many cases, you can have both problems, and I would say it's quite common. Then I always am interested in medications, particularly medications that a lot of my patients are on. So cardiovascular medications, beta blockers specifically, can cause erectile dysfunction. Antidepressants, it seems like everybody's on Lexapro or other types of SSRIs. Those are well described to cause erectile problems. And if a patient has not had erectile dysfunction in the past and then later develops it after they start an SSRI, I often think that that's going to be the implicated agent. And we can often fix that by changing the antidepressant class. So for example, bupropion, it's another type of antidepressant, but doesn't have the sexual dysfunction. It's often used to treat hyposexual desire disorder. And for patients who need to be on the SSRI for some reason, augmentation with bupropion can help to often reverse the sexual side effects. So that's a consideration. Certain hormonal agents, I think about finasteride and dutasteride as a hair loss expert. I put a lot of patients on finasteride and although finasteride has gotten a little bit of a bad reputation, it is true. In 2 to 3% of patients, they will develop sexual side effects, libido issues, and erectile dysfunction. And so if that's the case, we often have to stop those medications. And then a variety of other things, opiates, chronic cannabis use, alcohol, excess use, cannabis, frequently overuse can lead to erectile dysfunction, and a variety of other things. So that's erectile function. And we'll talk about how to address erectile dysfunction, and how to optimize erectile function here in a second. Then the other side of it, in terms of male sexual function, is libido. Right? So libido is the desire to have sex. You can have the most engorged penis that is ready to perform, but if you have no desire, no interest, you're missing half of that equation. So when I think about that, I think about intrinsically low libido. So some people just have a low sex drive, and that's a long-term chronic issue that they deal with throughout their lifespan. And various life events may happen in which it may be higher or lower, but it's just sort of there's a spectrum of libido. Some people have a much higher sex drive, some people have lower. And there probably is a diminishing of libido over time. So as testosterone levels decline in a man, as they enter into their 4th, 5th, 6th decade and beyond, libido is going to decline with those falling testosterone levels. And oftentimes patients will come to me, and that's a prominent symptom. It's distressing for them, and that is rationale for wanting to normalize testosterone levels to a young male range for a man who's, for example, in their 60s or 70s, is in order to restore that libido. Many of my patients will tell me, listen, I couldn't get enough of it when I was 20s or 30s, and I don't want it as much. Well, some of them are perfectly fine with that. They just sort of accept that as the aging process. Others say, I'm absolutely not okay with that, and I want to go back to having sex 4 or 5 times a day and wanting it, in which case we have to address one of the major drivers of that, which is testosterone. But given the same level of testosterone among several men, there is just variation in terms of intrinsic libido. Some people have a higher libido or lower libido at baseline. Some patients say, listen, I have sex 2 or 3 times a month and I feel great about it. That's exactly where I want to be. That's where my wife or my partner wants to be. And they're perfectly happy. Others are incredibly distressed because they only want to have sex 2 or 3 times a week, and they're having sex 2 or 3 times a week, and their partner is okay with that, but they want to be having sex 4 or 5, 6 times a week. So there is some subjectivity there, but ultimately that's an important consideration. And then there's situationally low libido as well. So relationship stress, job stress, health problems, all these things can lead to sort of this acute hit to libido, depressive episodes, anxiety, various mental health issues as well. So we want to think about this sort of acute situational libido reduction, and then we want to talk about the sort of long-term intrinsic libido of an individual. And what I often see is in my patients is this sort of acute on chronic dysfunction. So maybe as they get older, the libido is sort of declining, and then they get these hits because they have a health episode, or they're having some interrelational problems with their partner, or they have some workplace stress, and that 1-2 hit plus the SSRI that they're on for their moderate seasonal depression can be the kicker. So it's important to suss out what is going on. That often becomes an important conversation. And then I would mention as well, premature ejaculation is an important consideration. Often in younger men, it can be a lifelong or an acquired phenomenon. And interestingly enough, the SSRIs that we've just lambasted as causing erectile dysfunction are actually the first line of therapy for premature ejaculation. So the idea is that it increases a threshold, let's say, to ejaculate. And so low dose use of that is reasonable in that patient population. And then of course, partner issues. The reality is that 2 people can have very different attitudes about what constitutes a happy and healthy sex life, and that can refer to the cadence of having sex, that can refer to the sex practices, that can refer to whether the relationship is monogamous, monogamish, or totally open. And so those partner issues can often interfere and lead to sexual dysfunction. And that's, of course, requires open communication, compromise, counseling if necessary. So when I think about addressing male sexual function, dysfunction, and optimization, we have a couple of different agents, and we sort of use them in this kind of rational way depending on what's going on. So I spoke to you for 10 minutes about the different elements, libido, or erectile function, the different components of erectile dysfunction. So when we talk about the tools in our arsenal, you'll understand that we can address certain elements well and other elements not so well, and we often need to combine them in different ways. So the mainstay of therapy are going to be PDE inhibitors, phosphodiesterase inhibitors. This is classically Viagra, this is Levitra, this is Cialis, and of course, generic names, tadalafil for Cialis and sildenafil for Viagra, for example. And these are, of course, blockbuster medications because they increased relaxation of the blood vessels in the penis and allow it to get engorged and stay engorged longer. And so for men with vascular erectile dysfunction and in many cases neurogenic erectile dysfunction, this kind of organic erectile dysfunction, they work amazingly. They allow them to often cross that threshold to be able to get the erection and maintain it for longer. They are also incredibly effective for psychogenic erectile dysfunction. So for patients who just don't have a lot of confidence, if they are able to get rock hard with the slightest provocation, and then they have some counterproductive self-defeating thought about how they're for sure going to lose their erection and they're never going to be able to satisfy their wife, but they're looking at their penis and it's not getting soft because they have this medication on board, that often gives them the confidence to sort of get back in the act, refocus, and stop sort of self-reflecting on their impotence, so to speak. And so they're incredibly effective. I want to add a couple of little elements about how I think about the phosphodiesterase inhibitors. So tadalafil or Cialis is the longest lasting, but it takes the longest to kick in, about 30 minutes to an hour to kick in, but it lasts for 24 or even 36 hours. So we think of it as the weekend pill. Many of my patients will take 5 milligrams a day. You can take that every single day and you're sort of ready to party when you need to. So that's really fantastic there. And then it can be re-upped at the time of the event or around the time of the event with another 5 to 10 milligrams of the same agent. But again, it requires 30 minutes to an hour to get the effect of it. Other patients do an on-demand approach where they take 10 to 20 milligrams as needed, half to an hour before the episode. But again, it gives that long window of opportunity. The advantage of Viagra or Cialis, sildenafil, and Levitra, which is vardenafil, is that they are very fast acting, right? So they don't last as long, but they're very fast acting. So Viagra, half an hour for sure, the overwhelming majority, 70-80% of men are ready to perform. But in a large subset, 50% plus, that can be as early as 20 or even 15 minutes. So you can imagine the moment it strikes itself, you take the pill, 15, 20 minutes is pretty quick and you're ready to party. So that's the real advantage of that. Similarly, Levitra is also fantastic and it's even faster acting than Viagra. And I've read studies in which they look at a population of men and see how the time to erection. And again, it can be as early as 12 minutes. And by 15 to 20 minutes, actually a majority of men are able to, are having an effect of the medication. And so that's the real advantage of Viagra and Levitra. I think a rational approach can often be the 5 milligrams of Cialis sort of in the background for a man with erectile dysfunction or a man who just wants to have a harder erection, and then an as-needed dosing of Levitra or Viagra if necessary. And that can be based on situational specific characteristics. I next want to mention, I should also mention Viagra and phosphodiesterase inhibitors do nothing for libido, right? So you have to have the intrinsic drive to have sex. You have to be horny, so to speak, for them to do anything, right? So without sexual stimulus and without the sort of cerebral motivation to have sex, it really doesn't work, or it works very minimally. And so that's very, very important because they work on the erection and they work very well for organic erectile dysfunction of all types. They work very well for psychogenic and mixed erectile dysfunction, but they really don't do anything for the libido. And so we'll address that here in a second. I want to mention next arginine and citrulline. So nitric oxide is what phosphodiesterase inhibitors ultimately increase the levels up, and that's what causes the vasodilation in the blood vessel of the penis. So the blood vessels dilate, it allows the penis to get and stay engorged for longer. Well, arginine and citrulline are an amino acid and an amino acid precursor, respectively, that are the donator of the nitric oxide. That's ultimately where the nitric oxide comes from, is from the amino acid arginine. Unfortunately, if you take oral arginine, it's rapidly metabolized by the liver, and so not a lot of it gets to the blood. So citrulline is sort of a precursor of that. So there are a couple of studies that show that augmentation of a phosphodiesterase inhibitor, Cialis, for example, with a daily, for example, 2 grams twice a day to 5 grams twice a day, somewhere in that range of either arginine or citrulline, there's evidence for both, can potentiate it and give a stronger, more effective action. And so for my patients, for example, who have blood pressure issues. It's also been shown to lower blood pressure in a non-significant, I should say non-trivial way, in a significant way, by a couple of points. It increases vasodilation, so some people say that it gives them a better pump in the gym, makes their muscles look a little more swole. And so people who are interested in supplements and want a rational approach to supplements, who are maybe interested in, they don't want to go up on their dose of Viagra or Cialis, but they just want a little extra kick, I'll recommend 2 to 5 grams twice a day of those amino acid or the amino acid precursor citrulline. So then, as we said, that there's this age-related decline in testosterone. We have a lot of different approaches to addressing testosterone: injecting testosterone, Clomid, which I'm a huge fan of, which increases endogenous stimulation. That means inside your brain, you're increasing stimulation to the downstream and ultimately the testicles to produce testosterone while maintaining fertility. That's an approach I think works very well for many men who want to maintain their fertility. And then there are a couple of supplements that are evidence-based. The evidence is, I would call it moderate quality, but pretty directionally positive, for Ashwaganda and Tongkat Ali. So you'll see these, these are very popular in the biohacker communities. There's a lot of nonsense about it, but there's also some real science there. And Ashwagandha, for example, has been used for thousands of years in Ayurvedic medicine. There's this KSM 66 is the standardized extract of it, and that can be dosed twice a day. And it seems to increase testosterone, not in a massive way, but at 10 to 15% over 6 to 12 weeks. Why that's important is you can imagine a man who has sort of age-related decline in testosterone, and it just pushes them over the edge where their libido is not where it wants to be, and they undertake some resistance exercise, they're getting good sleep, everything's fine, but they're just not quite where they want to be. You can imagine that increasing that testosterone 10, maybe 15% over 6 weeks just gets them right into that zone where they're happy about it. It's not massive, it's not the same as injecting testosterone, but as an add-on, it may give them the little zhuzh that they need. And the same with Tongkat Ali. There are standardized extracts of it that I can link to. Importantly, testosterone is a key determinant of erectile function. It is a key determinant of libido. So we've talked about testosterone as a way to address libido. There is one agent which I find very exciting, and that is a herb from the Andes called maca, specifically black maca in Men's Health, and comes as a powder. The gelatinized version is much better tolerated, and that has been shown, interestingly enough, to improve libido without really doing anything to hormones. It doesn't increase testosterone, doesn't increase blood vessel dilation to the penis or anything like that. It seems to have these cerebral effects and increases libido. I'd be curious if any here has had experience with black maca. I've heard anecdotally when I read on different forums after reading some of the literature on the topic, then I go on Reddit and try to understand people's perspectives. Apparently there's this company, the Maca company, that makes incredibly high quality standardized gelatinized black maca dosed at about 3 to 5 grams daily, and it takes a few weeks to see the effects of it. And interestingly, that has been explored, like I said, specifically to increase libido without addressing or interfering with other hormonal effects, testosterone and other things. And then finally, I want to talk and end this with an anecdote about a peptide which I find very interesting and also seems to address libido specifically without doing anything to erectile function. So I'm a dermatologist, that's my profession. There is this guy, I'm sure you've heard of him before, his name is Watson of Watson and Crick. They were the discoverers of DNA, and they actually got the Nobel Prize for DNA. And that was, I want to say, 50 years ago. Well, this guy Watson, apparently in the last 30, 40 years after he discovered DNA, had gone down these fringe rabbit hole theories about genetics, and these sort of racial genetic ideas that are unpopular or taboo to talk about. And he's sort of been kind of a little disenchanted. The scientific community has become disenchanted with him. And one of the things that he advocated for a long time is that darker skinned individuals in the Southern Hemisphere, he posited that they have higher libido and higher sexuality. He famously said, you don't choose a British lover, you choose a Latin lover, right? Implying that the darker skin makes them more libidinous, and something about the sun and the darker skin increases libido. And so I always thought that was kind of interesting, but kind of a fringe nonsense thing. And as a dermatologist, I think about skin color all the time. I think about pigment problems, those kind of things. And we don't really think about that in the context of libido. So that's part one of the story. Part two. There is this thing that bodybuilders use called melanotan. So when they do their bodybuilding competition, they're rated on a variety of things: how symmetrical their muscles are, how the hypertrophy, how large the muscles are. But one of the characteristics that is very valuable for them is having a good tan and having a good color to their skin, looking healthy, basically. So they inject this compound called melanotan, which is melanocyte stimulating hormone analog. It's a version of that, the same hormone that is released when the sun comes out and you are exposed to the sun and you need to increase pigmentation in your skin. And so basically by injecting this hormone into their butt or their fat, it increases stimulation for pigmentation by mimicking the effects of this hormone called melanocyte stimulating hormone. And it's a great drug for giving that effect and gives you sunless tanning. But it has this unfortunate side effect. It causes erections, and of course, it's embarrassing for these bodybuilders to have erections while they're doing their bodybuilding competitions. And so I thought that was kind of interesting, and especially in the context of the story with Watson and this idea that darker skinned people are more libidinous. I thought that was when I learned that, I thought that was an interesting anecdote. And it's interesting, they actually have to do a variety of things, like inject things into their penis in order to make it soft, because it's sort of, again, it's not at the level of the penis, it seems to be at the level of the brain that this peptide is working. So there is now an FDA-approved medication that has gone through the FDA process that is a recombinant version of, recombinant meaning it's similar but differs by a couple of amino acid peptide, of melanocyte stimulating hormone called bremelanotide. And it's just a version of the same melanotan that these bodybuilders used to inject, and it is approved for the treatment of female hyposexual disorder. So some women have constitutionally low sexual drive, and it's a real issue. There's no Viagra for women. So consequently, it's a sort of area that has been explored, and people are very interested in it, and a couple of agents have come out, but they've been very underwhelming. But this medication, bremelanotide, which is an injection, works, and there's across the FDA required endpoints. And so the way it's approved is 45 minutes before the desired sexual episode, they inject themselves. The major side effect is nausea. It's apparently quite nauseating, but it works very well to increase libido in both men and women. And the FDA has only approved it for up to 8 times a month. And you can guess why, because if you use it more than 8 times a month, it causes excessive tanning. And also the worry is that it could stimulate the melanocytes, which could form melanoma, right? If you're just constantly stimulating your melanin producing cells, you can imagine that could potentially lead to a cancer. So I thought that story was really interesting because it highlights this kind of fringe crackpot idea of the relationship between dark colored skin and libido. And of course, there's a lot more nuance to it. But the point is that there is at least some rationale in terms of being mediated by this hormone. So for patients who want to have increased libido, the maca is not working, or it's predominantly an issue from above, or they just want to have optimization. They just want to have more sex, and they want to do what they're going to do and go longer and have more episodes and potentially a lower refractory period. We know that Viagra reduces the refractory period. It's the time that man is soft before he can get hard again. Bremelanotide is available as an injection, and also it is compounded as a nasal spray. So it's obviously a lot more desirable to do a nasal spray 45 minutes to an hour before the desired episode, up to 8 times per month. And I've had some very good luck with female patients and male patients, and it seems to work very well for that. And again, addresses libido at the level of the brain, right? This is doing nothing to the penis. It's doing nothing elsewhere in the body. And so I think it's a fascinating mechanism of action, and really reminds us that libido and sexuality is multifaceted. Of course, it requires the penis, but there's a lot of cerebral level elements that we just don't yet understand. So I hope you found this interesting and instructive, how we think about male sexual function, dysfunction, optimization, the tools in our toolbox. Of course, you got to get sleep right, you got to get nutrition right. Resistance exercise is critically important, stress reduction, partner factors. But given all those things are squared away, how do we optimize and address potential dysfunction? I've showed you the tools that we have. In subsequent discussions, we'll talk about how to protect yourself from sexually transmitted infection. We'll talk about the important sexually transmitted infections, including emerging ones like monkeypox, and what I see and how I really try to bottom out my risk for my patients of acquiring sexually transmitted infections. And we'll talk about TRT and other related topics. So if you like this content and you want more of it, please feel free to comment, subscribe, and get those alerts. We have a lot of good content coming your way. And again, I'm Dr. Sheikh, and thank you so much for your time and listening.